Resistance to the multi-drug therapy that was introduced in the 1960s was not seen as a great concern until the early 1990s. Since then, the United States presented more and more with a more resistant type of tuberculosis for which the multi-drug therapy did not cure. Especially HIV-infected people started to present with a multi-drug resistant type of tuberculosis, which caused to increase mortality enormously under both HIV-infected and uninfected. This initiated the world to see multi-drug resistance in tuberculosis as a worldwide high threat for the population and initiated countries to act. 1. Generally, multi-drug resistance TB, MDR-TB, is distinguished from resistance to a single agent since MDR-TB forms a much greater threat for the patient. MDR-TB is caused by bacteria that are resistant to at least two of the most potent first-line anti-TB drugs, isoniazid, INH, and rifampicin, or IF. Resistance can be either acquired at infection or developed during the multi-drug treatment of the bacteria. Resistance acquired at infection means that the invader type of Mycobacterium tuberculosis is a resistant one. HIV epidemics and the development of drug resistance in tuberculosis relate very intensively because HIV-infected people are highly vulnerable to bacterial infection, causing TB to spread very easily in HIV pandemic areas. HIV pandemic areas are thus a big risk factor for the in-treatment acquired multi-drug resistant tuberculosis. 1. One significant way to reduce the spread of antimicrobial resistance is to minimize treatment, which can be accomplished by preventing infection. If less individuals are infected by the pathogen, then a lower number of people need to be treated with antibiotics. Treatment with antibiotics always induces the formation of new resistant bacterial growth, which should therefore be minimized. Minimizing the risk of infection can be acquired through TB control programs, but also through the containment of HIV epidemics. 3, since HIV infection shows to be a risk factor. A small side note is that minimalizing treatment can be beneficial for resistance in those who do not suffer from infection, but should be researched properly in those who are infected. Resistance may be built up if antibiotic programs are not fulfilled for a proper duration, since some bacteria may survive. Therefore, the level and duration of dosage for adequate treatment of TB should be optimized to deal with resistance and cannot just be minimized. Another approach to minimize the spread of MDR-TB in the population is to specifically focus on the infection and spread of the specific resistant TB bacteria. If we monitor this spread, we can isolate those who are infected with a resistant type of TB and treat them with a specific second-line multi-drug treatment. These individuals will then be less likely to infect others again with their TB. For this to be effective, it is essential to detect which TB bacteria are resistant to what drugs and which are not. A new technique that enables this differentiation is whole genome sequencing, WGS, for the surveillance of tuberculosis drug resistance. 4. A study done in China concluded that WGS is very effective in identifying the resistant type of tuberculosis bacteria. 4. WGS enables more precise targeting of antibiotics on the exact bacterium because WGS identifies resistance qualification of the specific bacterium. In this way, therapeutic consequences may be to change specific antibiotics for which the bacterium is resistant to another, which is very potent. In this way, MDR-TB can be controlled and treated more effectively, which also contributes to a lower spread rate. 4. Hereby, think about early isolation of patients with MDR-TB and doing contact tracing research. Another promising way to prevent or treat MDR-TB is the introduction of vaccines. Next to the standard preventive vaccines, new therapeutic vaccines are researched in clinical trials. They can be used as an adjunctive therapy to people already diagnosed with tuberculosis to prevent relapse of the infection. 5. The only vaccine that is approved currently is the Bacillus calmette-guerin (BCG) vaccine. This was originally aimed at the reactivation of latent tuberculosis infection, but also shows to have effect on initial infection. 6. In conclusion, MDR-TB is a severe problem for which a simple solution is not applicable. 7. Combination of new vaccination, adequate second-line therapy to treat the MDR-TB, prevention of infection, and probably most valuable early diagnosis are factors which could support in the combat against this resistant tuberculosis.